Hi, welcome to Case of the Day. And today is the 92nd case. And for everyone, happy Ganesh Chaturthi, Michami Dukram to all the giants out there. And I wasn't going to do a case today because it was a holiday, but I was following up some patients and I got a follow up of this patient. So I said, then it makes sense and we can go ahead and talk about it. So today is the 92nd case titled A Diagnosis to Think About Even in Non-Epidemic Situations. And this is a 44-year-old, 2-month history of breathlessness, normal 6 minutes walk test. And that's scroll through the images. You can clearly see that there's ill-defined patchy ground glass throughout the lungs, more in the dependent portions, more in the lower lobes, some linear opacities, but nothing else. There's no septal thickening, no ill-defined centrilobular nodules, none of the other findings that you would want with this. So while you could argue that there are very subtle ill-defined centrilobular nodules, these are not the ones that are characteristic of, let's say, hypersensitivity pneumonitis. So we just got ground glass, that's it. And if you look at my unified flow chart, where here non-fibrotic alveolar filling, and you have all these different patterns, and here we're dealing with ground glass, where the most likely possibility almost always is non-fibrotic HP. There was a scan done 2 weeks prior. Patient had seen a couple of physicians with no diagnosis. So this particular physician sent the patient across just to have a fresh, good scan and to have a look. Ground glass is defined as an area of increased attenuation, not obscuring the underlying bronchi and vessels, and it's typically due to an alveolar filling process by fluid or cells, and that's what we're seeing here. Ill-defined patchy areas of ground glass, reasonably symmetric. And I'd done a similar patient about 3.5 to 4 years ago, and that was a 59-year-old with a 1 week history. And if you're interested, you can follow this URL to go through that case. But typically, this is a longer list of differentials that we would think about in a setting like this. And you could even add connective tissue disease to the hypersensitivity pneumonitis pattern. But the patient was a non-smoker. That basic history we always take at our place. No cardiac issues, no septal thickening or pleural effusion. So we didn't really think of pulmonary edema. So these two are out. Now, COVID pneumonias have a different appearance, right? They have a more an organizing pneumonia pattern or perivascular ground glass. So this is not COVID. So you're left with these four. Tropical eosinophilia almost always is a combination of nodules and septal thickening, and that's not what this patient has. So superficially, it may look like a ground glass pattern, but it is not. So we're left with these three. I didn't have a drug history at the time. I did look at, and if you'd like to go through this, again, focus on the fact that these ill-defined centrilobular nodules make a difference when you're making a diagnosis of non-fibrotic hypersensitivity pneumonitis as a pattern. And today we would use the term bronchiolocentric interstitial pneumonia pattern. And if you'd like, you can go through this case one, and I've given a link at the top right here. And I remember that in the 90s and early to mid 2000s, I used to say, not day, in my reports that the findings are suggestive of hypersensitivity pneumonitis provided the patient is not a smoker, not in failure, and not immunocompromised. And for those of you who remember late 90s and mid 2000s, immunocompromised meant one specific diagnosis. And so this was my report, a diffuse ILD showing a non-fibrotic alveolar filling pattern, not an HP pattern, and etiology is indeterminate. Now, we got lucky as far as a diagnosis is concerned because the soft tissue windows showed right supraclavicular, infraclavicular nodes, and these clustered, very typical, multiple small clustered, some minimally enlarged axillary lymph nodes with a little bit of pericardial fluid. So now the patient has ground glass and adenopathy. So drug induced is out. And we're left with, it could be HP with a superadded infection, or then we're left with PCP, PJP. And so this was my final report here, where I added the adenopathy part, and then I said, please rule out PCP, PJP. And here the idea was to rule out an immunocompromised status. So we never say rule out HIV or RVD or PLH. You just say rule out an immunocompromised status. And then when I messaged the referring doctor, I did say, please check the HIV status. And then today, when I was following up, the physician told me that the patient was PLHA, that is a person living with HIV and AIDS with a CD4 count less than 50. And I remember my talk from 99, not known to be HIV. So you suspect HIV when the patient has all of these findings, and that included non-specific ground glass, as in our patient, these multiple clustered axillary lymph nodes, and then of course necrotic adenopathy, which I'm certain this patient will have or has in the supraclavicular region, and that pretty much is what you get. So these nodes have not yet been addressed, and the patient has been advised to get a biopsy done, and I'm sure they will. And if I get a further follow-up, I will put it up in the description. The bottom line is, we have to keep PCP, PJP, and therefore PLHA in mind in all patients, especially those between 20 and 60, with unexplained indeterminate ground glass. And sometimes it is only us radiologists who get to make the diagnosis in previously unknown patients. And so that is that list. When do you think about PLHA or PCP, PJP is in these situations where the ground glass has no other finding, and there's no additional finding that will help you in a non-smoker, right? Of course, a smoker can also have PLHA. Then it becomes a little difficult figuring out whether it is AMP, DIP, RB, etc., as compared to PCP, PJP. This is the free lecture that will be gone, I guess, in by the weekend by WhatsApp channel. Thank you so much for viewing this. Take care. Bye bye.